Hello and welcome to another brand new episode of the MEM1 Mosaic podcast. Today, I am super excited to have a brand new guest on with me today. Kunmi and I actually met on a train journey from London to Manchester. It turns out he's a doctor and I'm an MEM1 patient. And of course, we got chatting. I've asked him to come on today just to kind of share his perspective of what it's been like working in healthcare and any kind of nuggets of gold or wisdom that he might be able to share with you as MEM1 patients or really anyone who's here tuning into the episode today. I will shut up. I will let him introduce himself and then let's see where the conversation goes. So, welcome, Kunmi. It's so cool to have you here. As we said before, it's been a long time coming, and I'm very excited to have you on. You are my first A&E doctor. You're one of very few medics who is not directly related to the MEM1 condition, which I think is so valuable for a podcast like this, which is about diverse perspectives, opening up conversation and listening to what kind of everyone's input is. So I did say I was going to be quiet. I'm going to ask you if you can just introduce yourself, maybe tell us a little bit about your background and how you got into what you're doing now.
Mhm. Hi Liz, thank you for having me on here. It's been a long time coming, and I'm happy to finally be able to do this on the podcast. To everyone listening out there, my name is Kunmi George. I am an A&E doctor. I have been a medical doctor for about 8 years now, and so I'm not going to bore you with all the I'm not going to bore you with all the bits and bobs, but I did my medical education in Russia. And after that, I've had working experience in a couple of other places, like, in Nigeria. I worked in a couple of other places in England as well, doing different things from general practice to surgery to obs and gynae to family medicine. And now I've decided to stick with A&E. So I've worked as an A&E doctor in Manchester for almost 2 years now, and it's been quite the experience.
I love that. I feel like you've opened the path there for a depth of conversation. So I'm sure we'll dive into that and see where that takes us. So you mentioned that you did some training in Russia. I know you said you've worked abroad, Nigeria. One of the things that you and I got chatting about when we were on the train was the kind of different states of healthcare in those different places, in those different countries.
Mhm.
I, as an MEM1 patient, having been born in the UK, I've been under the NHS since I was diagnosed. I feel very blessed and very fortunate to have a free healthcare system to support me and to fund everything that I go through under the NHS, apologies, under the MEM1 bracket. How lucky are we as patients to have the system that we do? Are there drawbacks, from your perspective? What has working abroad shown you that is done better or done worse elsewhere? And yeah, if there's sort of something that maybe you could share with patients about what they might not see behind, behind the doors when they're, I say sitting on one side of the desk and you on the other, or I should say you might not sit behind a desk much in in A&E. What is it that that we don't realize we have and we're very fortunate to have?
Hmm. Thank you for that question, Lizzie. That's a really, really good question. I mean, considering the fact that I've seen both sides, been on both sides of, a working system and a system that doesn't really work. Um, Honestly, the NHS is one of the best things that has happened to the United Kingdom, in my opinion, in the sense that you have access to healthcare. Now, access is really key because you know that if you were ill, you would be looked after, whether it took 1 hour, whether it took a couple of hours, there's always that access to healthcare. And that's what many people fail to realize, that it's not the same in other parts of the world. And when I also talk about access, we're talking about free healthcare. You don't really have to pay for anything because they have their way of, getting this money from taxes and basically running the system. And it's really underrated because people just only see the drawbacks, the challenges, the waiting times and all. But it's a really fantastic initiative in the sense that if someone needed a liver transplant in the NHS, for example, they walked into the hospital, they're on a waiting list, and they met all the criteria, they get that without paying a dime. And it's fantastic because it just shows that both the rich, both the poor, both the middle class, everyone has access to the same amount of care and amenities, which is amazing. You don't always have to think off the top of your head, okay, look, I'm feeling unwell. Do I have to spend money to get this? If it's available in the NHS and you can get it, you will get it. Now, on the other hand, of course, everyone knows what's happening in the country now with the waiting times, the pressure on doctors. For me, as well as an A&E doctor, having to go to work, you have to make sure that everyone is everyone's needs are met basically when they come through those doors because they will have questions. They want to know what's going on. And sometimes you don't have all the answers. So you kind of have to meet them in the middle and say, look, I understand this is what's happening, but still, maintain that side of empathy, knowing that, okay, look, they are going through things and they just need to know if they will be fine or if they will get the much needed help. Now, if you look at things in other continents, for example, like Africa, the way healthcare is structured, for example, in Nigeria, where I'm from, it's a bit different. Here in the NHS, everything's a bit more centralized. If you're going to be referred to the hospital, if it's not an emergency, you go to your general practice, you see the GPs, and then they work the way up to the specialties, and then there's A&E as well, where you get seen for emergencies and then you're referred. In Nigeria, it's a bit different in the sense that most people would present to the hospitals through A&E or through their referral clinics, that's the specialty clinics and all. So it's not like here where everyone has to go through their GP. Most people just go through specialties. Maybe they've been referred by some doctors, they go directly to the specialties or from the accidents and emergencies. And even that the structure of the accidents and emergency is different because each department has their own accident and emergency. Whereas here in the United Kingdom, everyone goes through A&E. So everyone goes through the same A&E, whereas it's different back home where pediatrics have their own emergency, medicine has their own emergency, surgery has their own emergency. What that does is, for you as a doctor, in those A&Es, it limits the amount of exposure you have to certain types of conditions. Now, for example, if we're talking about MEN now, right, it would be seen as an endocrine issue. So that would be classified as a medical emergency. Now, if we were to approach that from the structure in, let's say, Africa now, in Nigeria, it means that those people would present through medical emergencies, right? They'll present to a medical emergency, rather than the whole general, A&E here in England. And this is from a government, this is how the government hospitals are run. For the private sector, it's a bit more different where, they have a general A&E and people get triaged and things like that. So it's been, I think one of the things that has been an eye-opener for me here, working in the United Kingdom is the they have continuity of care. So basically, you get that follow-up. You can be seen as a patient from age 1 till whenever needed, and all the records will be intact. There's continuity of care, all the appropriate referrals, all those things will be put in place. So the structure is there. So it's well structured. It's a well structured system. It has its drawbacks. It has its challenges from the side of personnel, from the side of funding, issues with the government, staffing, and all those things. But the NHS has still found a way to work. It's still found a way to make sure that patients are still getting the needed help. They're still getting the needed attention, medications, all that still in place.
This is fascinating, and you've opened my eyes up to a lot of things that I just didn't know or didn't see before. And I kind of like to pride myself as someone who's like got their eyes open already. And I'm like, wow, like there are so many different things that I hadn't taken into account. And I think hearing it from the perspective of a practitioner is very different to, for example, when we're in the patient communities, and quite understandably, as you said, in certain cases, people tend to look only at the drawbacks, but actually, we've got a system that works. And yes, it's currently this huge black hole, but ultimately, as I say, I'm an MEM1 patient. I'm in there. I'm in the system. I've been in there for years. I'm going to hang on to that, and make the most of the amazing care that I receive, and I feel very grateful for every day. And when you were speaking, it reminded me of a blog article I wrote recently. I think in patient forums, in patient discussions, there's very much a thing of like, we want our doctors to appreciate what it's like to sit on our side of the desk, and put themselves in our shoes. I'm a bit of a devil's advocate, and I would come in and argue, if patients are going to ask their professionals to do that, then it's quite all right for a professional to say, actually, maybe a patient should understand what it's like to work a day in my shoes. Can you tell us a bit about what that is like, a typical day? Obviously, you work in A&E, but I know you've worked in other areas as well. If I were a fly on the wall in a day in your life, what would that look like that I just wouldn't see otherwise, and that I might not be aware of?
Wow, that's interesting, because I think I'll look at it from an A&E perspective. It's like every normal day you start the day, with expectations. But the thing is, you can't really have expectations in the sense that you don't really know what to expect. Anything can walk through those doors, and you have to be prepared for whatever comes through the doors. And that's the thrill of working as an A&E doctor. You do not know what to expect. And it's so dynamic that you can start your shift in the morning, you have maybe 5 patients waiting to be seen. And 1 hour after, there's 20 people. By the time you're finishing the shift, there's 100 people waiting to be seen. And the amount of patients, that present sometimes, their acuity is different, in the sense that how ill they are is actually different. And that determines the amount of time that I, as an A&E doctor, or the team of doctors, will spend on individual patients. So there are days where you would come to work, there's loads of patients to be seen, but most of them are not so ill. Some get sent home, some get referred to other specialties, and they get the necessary treatment, and then they're sent away. And then there are days where you come to the hospital and people are really sick. Like, you have to spend more time with these patients that are acutely ill. And what happens with that is it prolongs the waiting times for other people to be seen as well. And that's where the complaints now come, and you hear people say, "Oh, I was in A&E for 4, 5, 6 hours. I wasn't seen." It's not because you do not want to be seen. It's because there's like people that have to be given priority as well when they come to the hospital. For example, someone who is having a heart attack or someone who's having a stroke would be given a bit more priority than someone who comes in with a cough, and a temperature. And of course, it's now down to clinical judgments from you as an A&E doctor as well to decide, okay, who needs what done first, who needs to be attended to immediately. So that's where the system also helps with triaging patients, and you as a doctor deciding, okay, this can wait 5 minutes, this can wait 10 minutes, this person needs to be seen immediately, that person can have this medication, that investigation. So as a doctor, it challenges your faculty of thought in the sense that you now have to decide, okay, how do I approach this from a time management perspective? Making sure that, I mean, in the NHS, there's a 4 hour target for each patient. Everything you need to do, that's from triage till they get discharged or admitted to the necessary specialties. It should be done within 4 hours. And so the trust will try to make sure that many of those patients do not breach, so they get the necessary help within that 4 hour target. Sometimes it's very difficult, depending on what they come in with, because as A&E doctors, what we do is it's kind of a holistic approach of care. It's not just about, okay, you've seen this patient, this is what you think they have. Now you have to do the initial treatment. Aside doing the initial treatment, you have to now decide which specialty they go to. What are they going to, that specialty, is the specialty going to accept? If there's other things that need to be done for them while you're waiting for those specialties to see them. So it's kind of like you also have to not just be a doctor, you also have to look at things from a human perspective, as a human being, like being empathic, understanding. So you have to have other skills, active listening, critical analysis, problem solving, time management. There's a whole lot that goes into working as a doctor that most people do not see, because they're just like, oh, you're a doctor, you should know what's going on with me. You understand? And if you think about, for example, MEN now, there's a whole triage or symptoms that people can experience. And if one, for somebody who has not seen a lot of that, when someone comes in and they are experiencing some of those symptoms, you would want to pin it to just one system, especially at the first presentation, because that's the last thing you most likely think of, except this patient or this person already knows their history and they say, okay, this is what I have, and this is what I have had done, then that helps. So the patients actually do us a lot of service by actually knowing things that are wrong with them, because it helps us to make informed decisions in terms of their management as well. So if a patient comes and says, oh, I've had this chest pain for X amount of time, and then you ask them follow-up questions, oh, has this happened before? And they say, oh, yeah, actually, I've had this procedure done. So it helps your train of thought. And you say, oh, okay, this has happened before. Then you start to think, okay, what are the other things that you need to rule out? What are the things that you need to exclude? What are the things that you need to include? So there's a whole lot of dynamics at play when you work as a doctor in the NHS. There are so many things to consider, and no 2 days are the same. That's another thing. So yes.
I love that. No 2 days are the same. And the funny thing is that a patient would say exactly the same thing. And I think we have sometimes more in common than we think, patients and professionals. I think there's so much scope and capacity to work together rather than feeling as though it's, having to be on sides. And I love what you said earlier about meeting in the middle. Your job is to have the empathy but also be pragmatic and give the medical care that you've been trained to give, and you need to meet a patient in the middle. And that's prompted my final question, and I could talk to you all day, by the way, but I do have to, unfortunately, for the purposes of time, bring this to a close.
Yeah.
My final question is, and I've begun asking this to a lot of the professionals that I speak to on this podcast, if, or in your opinion, what is one thing that patients, whether they have MEM1 or they don't have a disease, but that, they've ended up in A&E or anything, what is it that a patient can do that's within their remit that then helps you as a medical professional to make that healthcare journey as smooth as possible?
Hmm. That's a very good question. One thing that a patient can do. The first thing I would say is do not ignore symptoms. So if you've had something that has lasted for more than 1-2 days, a particular symptom, it's not something that you should just brush off. It might be something more sinister. It might just be a one-off episode as well. And that's why for us as doctors, we get to, make that call sometimes and say, okay, look, this has been going on for a while. And then you come in and we assess you, do all the investigations, and then we're satisfied and say, okay, look, we're not worried about this being anything, serious. You're fine to, go home. So I would say, if I could give anyone one advice, do not ignore symptoms. Do not ignore things that are lingering more than 1-2 days. It's something you should always, even if it's just to give, your doctor a ring and say, oh, this is what's happening, that. So, and I think another thing would be for people to pay attention to their health. That's actually learning to look after themselves just by tweaking little things, one or two things that it might be just sleeping more, eating a bit more, drinking more, just adopting subtle lifestyle changes, 30-minute walks, having a nap here and there, stretching, exercising, just 1-2 things would go a long way. And it's not something that has to be intense, just something that you can ease into your day-to-day life, something that is enjoyable as well. So I think that's that's it.
I love the fact that you said enjoyable. And when I work with people, I tell them there's no point picking up a hobby or a sport or a type of exercise if you actually hate it from the moment you think about it to the moment you finish doing it. Fun is so important, and healthcare, looking after yourself, in my opinion, my experience, can be so fun. So I really am so grateful that you've added that in on the end, and very grateful just generally for the time that you've given over to this episode today. And as I say, I could go on chatting with you for the rest of the day and that wouldn't be enough. But I'm very excited to have had you on, to have brought a different kind of conversation into the podcast. And I really hope to have you back on at some point in the future and just keep sharing your nuggets of wisdom, as I called them.
Thank you for having me. This was amazing. I'd love to be back on here at some point in the nearest future, anyways, to have more conversations. Thank you for having me.
Thank you so much, Kunmi. It was so grateful.
Yeah.